said, my name is Maggie. I'm one of the third-year general surgery residents. I wanted to talk about an analysis of our care over recent years with regards to unplanned intubations in our surgical patients. So, unplanned intubation is a complex postoperative complication associated with severe adverse events and mortality. In the literature, that mortality rate is up to 43%, although that varies widely with the underlying cause of the event. Here at UC Davis, our institutional leadership identified an increased number of unplanned intubations here as compared to other institutions. So that prompted our retrospective review of our own data to see what caused this and what we can do to do better. And that required us to evaluate both the causes and the timing of these events. So we did this by using both NISQIP and trauma registries. We identified all unplanned intubation events between January 1st, 2013 and December 31st, 2016. The patient's charts were reviewed to identify key details about the event. Things like timing with regards to surgery, emergency versus elective surgery, chest x-rays, ABGs, narcotic intake, naloxone administration, BUN and creatinine levels, diuretic administration, things like that. And then using all of that information, we determined the underlying cause or the need for reintubation and characterize them into the following causes: fluid overload, sepsis, pneumonia, narcotic overdose, aspiration, unplanned return to the operating room, airway protection, pulmonary embolus, and finally other undetermined, as there were multiple cases that couldn't pinpoint exactly what the cause was. So the trauma registry identified, after exclusion of patients that didn't meet TQIP criteria, ultimately revealed 22 patients with 29 unplanned intubation events. And the most common cause was aspiration at 21%, followed by fluid pneumonia and fluid overload. And the average time between either initial extubation or presentation in the trauma bay was 5.6, plus or minus about a day. Amongst NISQIP patients, we had 44 patients with 48 unplanned intubations. The most common cause was fluid overload at 27%, followed by sepsis and then airway protection. And the average time was about 4 days. I wanted to talk a little bit about the timing of the unplanned intubations, because TQIP actually defines unplanned intubation as those that occur after 24 hours after extubation. So it misses all of those failed extubation attempts or reintubations within 24 hours, and that's why there's a 0 on day 0. In our data, that excluded 8 people, half of which were failed extubation attempts, and a few of them were self-extubation. So this is actually something that we presented at the TQIP conference in Chicago this fall to try to kind of discuss potentially changing their definition. And so it kind of skews our data a little bit. So to talk a little bit more specifically about our results, we noticed that there's a difference with regard to the underlying causes of unplanned intubation between trauma and non-trauma patients. And they also differ somewhat from what's reported in the literature. Causes of unplanned intubation amongst trauma patients is not clearly elucidated in the literature, although there seems to be higher rates amongst patients with TBI and pulmonary contusion. For TBI, our rate was about 27% of our patients with unplanned intubation had TBI, but interestingly, about 40% of the aspiration events were in patients with TBI. So because aspiration was our most common cause, we looked a little bit more into that. We thought initially that maybe this was related to C-collar usage and elderly patients. Only one of those patients actually had a C-collar. The average age of the patients was about 70 years. And really the most common thing that we found underlying these aspiration events was inadvertent removal of either post-pyloric feeding tubes or NG decompressing tubes. And so that's specifically a key target with regards to quality improvement. Amongst our NISQIP patients, the most common cause was fluid overload, and this is not what's been reported in the literature. The most common cause in the literature is sepsis, and so I think this is our key thing that we can do here at UC Davis, I think, to improve. And with regard to the fluid overload events, these patients weren't re-intubated and then kind of quickly diuresed and extubated, their average length of intubation was about 6 days. So what do we conclude? We conclude that we have an increased number of unplanned intubation as compared to other institutions, that our causes differ from that which is reported in the literature, and those are the key areas to improve here at UCD. So we've developed a few things that we'd like to take forward to prevent this morbid event in our patients. The first is fluid management education, which we've begun here. The idea of potentially securing vital and tear tubes, whether that be with a suture or a bridling device. Decreasing our opioid intake, which we definitely already have begun doing. And then increasing in mobility of our patients, whether that be our kind of continued effort to increase the amount of physical therapy resources we have here, or just trying to get our patients more mobile, even in the absence of official physical therapy. Can you take any questions? I agree, and I think looking back, this has sparked a lot of discussion amongst residents and staff, and I don't think it's necessarily with how we're resuscitating patients. I think we do a pretty good job of resuscitating patients. I think it's actually the post-operative period and maybe not using diuresis as aggressive as we should, or not paying close enough attention. Sometimes, the day that this is occurring is more like post-op day 4, so it's kind of when you would expect mobilization of fluids, and I think a lot of that might have to do with the transfer of care from the ICU to the floor, and maybe we're not being quite as vigilant about their overall fluid status once they come out to the ward. Who do we expect to need to be diuresed chemically, or there were several patients who were just left on maintenance fluids on the floor when they came out of the ICU that certainly didn't need them, and that was the sole cause of them needing to be reintubated. So I think that is kind of the area that we need to improve on, not necessarily our initial resuscitation, but how we're taking care of them after that. We do have some of that data. I don't have the numbers off the top of my head, but a large number of them are and we definitely saw both, especially with regards to our both within the ICU.
All right. Morning, everybody. Great. So I'm here to present to you our division study, or my personal study, on a single surgeon experience using post-operative training breast reduction for the reduction plan. So I want to start off and just talk briefly on the use of drains. It's pretty prevalent. The use of these drains is very commonly found in every region of the body after you perform surgery. We know post-operative drains, whenever there's an insult to the body, whenever you have such dead space, the body wants to fill that space with fluid. Drains are a great way to egress that fluid out without your body to heal. However, no prevention without its risks, and we saw with that mind as residents. The use of surgical drains also falls within that category. We know that there's always inherent risk to surgical drains, including infections, as well as the psychological well-being of patients. People really don't like having devices in their body. Sometimes it's actually stated that it is a hindrance to post-operative mobilization, having these patients kind of feel back to normal to get them out of bed, get them on with their daily activities. So, what does the evidence really show? Well, we know that a lot of meta-analysis has been done that there's really not a lot of good evidence to suggest that drains are useful for things like hemolysis. Because we all know that the bleeding arteries however, it is sensible to point on that. Also, there's debate as to whether or not the use of drain is really at all in certain procedures. So, what we wanted to look at, well, here's my little interloper. I know it's not the most interesting topic, but reduction anaplasty is our personal study. I thought, well, what other things are reductions? You have mathematical reductions, you have orthopedic with bone reduction, you actually have my favorite. Just learn how to do this absolutely blind reduction or food. Try and get into cooking. But we're going to talk today about breast reduction, specifically the use of drains in breast reduction, or reduction anaplasty. So in the field of plastic surgery, in my experience, breast reduction is a lot of thought. So I was a medical student. There's only one way to tie it, and you always use drains. And the word always is represents, at least what we teach you, not maybe what the evidence suggests. So what does the evidence suggest when it comes to reduction anaplasty or breast reduction? Well, in 2003, this is one of the better, higher level evidence papers. They found that there was an indication in breast reduction for certain indications, including section rates greater than 500 500 grams, as well as obese patients. However, moving forward a couple more years, in 2008, another study showed that actually this is the best study to date in the field of plastic surgery breast reduction. So it's level 2 is a prospective controlled or prospective randomized trial where they just divvied up blinded, started randomized, because some of the patients received drains, some didn't, and they actually showed that there was no significant outcome scrofa, as well as wound complications. However, they did not stratify the wound complications as to what they meant with healing, flap failure. So, there was a meta-analysis years later, I think this was in 2013, that again surmised all the data, and simply put, the pendulum has now swung from, I think, the evidence shows that maybe there was a role for brain to possibly not. However, we here wanted to, I thought it would be a very interesting question to use a surgeon's experience, so controlling for that factor, whether or not drains, what our own personal experience was with that. So, what we conducted was a retrospective review, single surgeon here. It was through the course of 7 years, essentially 2010 to 2017, 17 consecutive patients, and 144 consecutive breasts. And you see here our demographics. Note our demographics for our own patients aren't too different than the Korean study, which I showed you guys in the last slide. Mean age of 46 years old, BMI about 27, which is anecdotally pretty surprising because it seems like most of the patients I've done breast reductions on in resident or greater than that. But and you can see a reduction in weights there for Porcine, or about 4%, about 450. And our results, what do we find? Surprisingly or unsurprisingly, there was no statistically significant differences or results when it came to our outcomes. These are just big global outcomes. Minor wound complications, also seroma, hematoma infection, and also a subjective category we like to call SWOT. Patients who survive. So that was something we tried to capture with the chart review. But again, when you take a look at the data analysis, there's actually no So, in conclusion, there's no significant differences between the use of postoperative drain and breast reduction. This does follow permanent strength or the this suggests that you really don't need it. This, of course, we understand can be of multiple benefits for the patients because a lot of these patients are ambulatory. Our practice here is that most of these patients feel like they're so sick. So, in conclusion, this also matches our American Society of Plastic Surgery Society's guidelines, which they do not recommend brain. However, the future direction I think personally, I would love to stratify. Coming back to the complications. So anyway, thank you guys for listening. Questions? Possibly, you're 100% correct to get to that result side here. Excuse me, but yes, I think it would be interesting. Moving forward, great question. So I will refer that to the that first maybe start to want that tomorrow. This is that practice because you had that brain versus now the about this object. So in the study, actually, Dr. Wong, when he first started the practice here at UCA, did use drains and breast reductions. But accordingly, in 2013, about that time, the society guidelines came out and said, we need, I think that's the practice patterns here for our semester also changed. So that was one of them. I'll see you next year. Same time, same place. Not yet. Yeah, no. I appreciate that feedback. Thank you so much, sir.
Hello, my name is Dr. Kashtan, one of the PGY4 research consultants for general surgery, and I'll be presenting the effects of prolonged hypothermia on extremity ischemia in the Porcine model of hemorrhage. Disclaimer, these are the opinions of my PIs and do not reflect the U.S. Air Force or Department of Defense. We also performed all of the animal testing in this under established guidelines, and tourniquet use has drastically improved the mortality in our recent conflicts in Iraq and Afghanistan. But at times this can be detrimental, obviously, to the limb that is being having tourniquet applied to it. They found that as little as 1 hour of tourniquet time in a setting of hemorrhage or shock can result in decreased limb function. Actually, another study is going to get presented today on the extirpation time for prolonged field care. Some soldiers could be spending upwards of 12 hours in the field before they reach any definitive medical care. So what we've been looking at is ways to prolong the amount of time that a tourniquet can be left in place and preserve limb function. Last year, Dr. Meryl Simon looked at external cooling in the setting of hemorrhage. She looked at using a zone 3 Reboa to produce extremity ischemia in a pig for 4 hours and applied external cooling to that limb compared it against just normal thermia. She saw some very promising results, nearly fourfold decrease in the amount of muscle breakdown products. And so for my study this year, we wanted to extend out the amount of time that we were leaving the zone 3 Reboa in place in order to see if this benefit we saw from external cooling would hold. So for the methods, we took 6 animals, 3 in each arm, and we submitted them to a 25% hemorrhage, then followed by a zone 3 Reboa inflation. We then randomized them to either 8 hours of external hypothermia using ice packs and cooling blankets, or normal thermia. After those 8 hours, we then took down the Reboa and 3 hours of critical care was performed using a standardized protocol. This first slide is the results that Dr. Simon saw last year. And what you can see, you have CK on the left and then myoglobin on the right. And you can see that there's a very statistically significant difference in the amount of breakdown products. So those animals that were given or exposed to hypothermia had almost a 4 to 5-fold decrease in their breakdown products seen in both CK and myoglobin. Unfortunately, for mine, we did not see the same amount of benefit. While our numbers trended lower, they did not become statistically significant based on the numbers of animals we used. We are still waiting our myoglobin results, but what we have presented here are CK and lactate dehydrogenase, which is also a muscle breakdown product. So, one of our overall conclusions was that while we certainly see a clear benefit of hypothermia at 4 hours, this benefit seems to decrease as you extend out your ischemic threshold. So, the one limitation we certainly noted in our study is that we're looking at lab markers, not actual function. So there's certainly a possibility that the function in the limbs could be preserved, or there could still be a functional benefit, even though we're not seeing as much of a laboratory benefit. But as of now, what we can say is that while the external cooling does appear to be beneficial, there should certainly be an intervention to reverse ischemia at this point prior to 8 hours. Our hypothermic goal was between 15 and 25 degrees centigrade. There's some evidence that actually ideal temperature is around 4 degrees for preserving tissue, but what we also aim for is an intervention that can be done in the field. And so we thought that trying to cool them to 4 degrees would probably not be feasible or practical in a military setting, and that using just ice packs and cooling blankets, we could accurately and reproducibly produce hypothermia to somewhere between 18 and 25 degrees. Really good question. I think a lot of the treatments right now are being in place in the last whether or not it's like that versus the study that they used for this was they took a certain period of work functional results. But they did not like 2 hours, 4 hours, 6 hours. Otherwise, yeah. Yeah, and we looked at that as well, and our thinking about why we didn't apply it for this situation was the average. You're going to have usually a medic level soldier who's going to be taking care of these patients, and their exposure to, or their ability to obtain vascular access as well as infuse cooled substance is probably going to be a little more limited than simply the ability to put on ice packs or anything like it. And so it's more of a logistical, less than a scientific reason for why we chose this method of cooling as opposed to that one.
Thank you very much.
All right, thank you everybody for your time today. So prosthetic reconstruction is a really good thing. Employers demand a very high quality. Typically, it's going to be a 30 to 60% rate, which we'll see in the literature. 23 to 50% of these are going to be major complications. A couple of examples of a major complication being right here with implant exposure or infection necessitating implant removal or just total implant reconstructive failure. Now, within recent years, that grafting really you can take a patient who looks like this and has dimples and skin that is really down to the chest wall. And in more recent years, we've been able to have problems as well. I don't know the health of that, but stromal cells and all those derived stem cells that stop it transfer. So taking fat from a healthy environment into a less healthy environment does seem to have beneficial effects on soft tissues in this area. Our hypothesis is that fat grafting is a radiated breast increases complications in implant-based breast reconstruction. So we've done a retrospective review of all of our patients who had undergone breast radiation and subsequent prosthetic reconstruction. These patients all had a submuscular tissue expander with a cellular dermal matrix sling and fat grafting performed either before the tissue expander or after, prior to their final implantation. We excluded all patients who had incomplete charts or less than a year followed up to. We were able to include 17 patients. We had 2 patients who were fat grafted before their tissue expander was put, considered prophylactic fat grafting. So popped on the chest wall. 15 after. 13 of our patients had radiation prior to their tissue expander placement. Many of these will have been patients either who delayed reconstruction or they had a previous one had which they later ended up missing. Overall, looking at our data, we had 12 patients with implant loss. 12% of our patients with implant loss. 6% of the stromas with breakdowns. And overall, major complication and total complications were 12%. If you compare the data, which is inconsistent depending on the study that's done, but in aggregate, relatively high, our results do seem to be favorable and seem to be conferring a benefit to our patient with regard to the complications that we're experiencing. I would like to point out that our major complications have experienced 15 failures as well. both patients one of which went on to have a solid rotissemus and the other one just developed skin closure. The other major point on that was both occurred 6 months after use. And what you would initially be expecting to do with stag grafting is increase shorter term complications, as we know they can see that we're having problems. So, an operation will be difficult to know. It's just an example of what you see with some of these patients. We go from pre-mastectomy to the result to one who has notable radiation changes as well as capsular fracture. And the whole point of doing this fat grafting is to soften up this soft tissue in the foot. This is in addition to what you're doing with capsular. But if you look at the final result, you notice that the skin color is a little better. There's a softer skin quality. The rest just looks a little bit healthier. So, in conclusion, our major and overall complication rates of 12% and 23% respectively compare favorably to reported values. And fat grafting may decrease these complications and complication from the patient population. The largest study is going forward. Thank you, Dr. Wong and Dr. Sala, for your help with this project, and I'll be happy to answer your questions. What would be nice to do is look back a little further and get some more patients. Like, in terms of the complications that are, of course, it's hard at the moment.
So, when is it best?
As to where it comes from, how to backgrafts, I suspect that it is helping with tissue quality, which can skin and soft tissue as prone to breakdown and subsequent infection. So, I compared that only to patients who have traditional two-stage reconstruction and are radiated, not with the fat grafting.
Which is great.
Sorry. Yeah. Excuse me.
So as mentioned, I'm Dr. Evans, and we'll be presenting our brief experience with the prophylactic implantation of the Impella left ventricular assist device for high-risk cardiac surgery. So an introduction and background on this is that the Impella temporary left ventricular assist device is increasingly utilized. It's often a percutaneously placed device that sits across the aortic valve and helps assist the left ventricle. It's a well-established therapy, and it's gaining increased use for what we call a protected PCI, or a high-risk coronary interventions in a cath lab where they place stents percutaneously. They'll often use the Impella device to help assist with that procedure and stability during their case. However, it's not routinely used in patients undergoing cardiac operations, and so its application in this environment is unknown. It is gaining increased interest nationwide for what we're referring to as extreme risk surgery, which is usually for those patients that would normally be of prohibitive surgical risk. So patients who have a low ejection fraction have a significantly increased risk of morbidity and mortality with the open heart surgery operations, and thus those would be perfect candidates to help ameliorate that risk by assisting with the left ventricular device. There's no existing case series in the literature at present for describing the use of the Impella for this indication, and so we review our center experience with that use for this novel application. For methods for this, it was just a retrospective observational study. So all patients that underwent implantation of the Impella LVAD prior to a planned cardiac surgical intervention that was performed at our institution over the last year between August of 2016 to 2017, all of the patients had a very low preoperative EF, between 15 to 25%, and as you may recall, 30% is the established diagnosis for heart failure. So they were considered very high risk. So how we do it, we implant it for all the patients included in the study. We implant it via the right axillary artery usually, where we access the axillary artery and the delta temporal groove, sew a graft onto that we then tunnel externally, and then place the Impella device through that graft and then into the aorta where it sits across the aortic valve. So you can see in that radiographic image over on the right, that red line denotes the location of the aortic valve. So you can see how the device itself, which is that little L-shaped device in there, sits across the valve, and a little pigtail that sits within the left ventricle sits just distal to that inflow catheter that helps centrifuge suck the blood out of that left ventricle, and then a prosthetic valve, and then basically distribute it in the aorta via that more radial big marker that's called the aortic grafting. We could also implant it directly onto the aorta, as we see in this picture here. So you can sew graft directly onto the aorta itself. The orientation of this photo is the patient's head is to the left, feet to the right, and the cross clamp, which is the metal clamp, there is a cross clamp in the aorta, so you can see the graft sewn directly to the aorta. And this is what it looks like when we're all done. So we leave that graft in place, tunneled externally, and you can see the drive line coming from the right axillary to the external display monitor. So this is the results of our study. There are a few minor complications. We had 6 patients total here. We've subsequently done a couple more. And the minor complications included seroma and then dislodgement of that device where it just came out of optimal position. It is something you can reposition in the ICU under echo guidance. So overall, that doesn't usually result in any major complications. The major complications that we would have, that we were looking at, is things like cardiogenic shock, stroke, renal failure, 30-day mortality, and post-cardiotomy syndrome. Overall, the patients didn't have any of those, so none of those were experienced, and they had 100% survival, which is actually kind of shocking given that all these patients had basically prohibitive surgical risk going into the operation. We've subsequently done 2 more of these cases, and they also survived and did well. And overall, they had a relatively low length of stay period. So post-operative days supported with the LVAD, keep that in place for a period of time to allow for cardiac recovery. And then after removal of that device, their stay really wasn't that much more prolonged than original, like open cardiac surgery. In general, patients stay on average 7 days for what we would say a healthy post-operative basic cardiac surgery patient. Now, interestingly, the STS 30-day mortality risk and morbidity score included in our study, because that's what nationally we all kind of refer to as far as the post-operative morbidity mortality, much like the lung score. But interestingly, it's not predictive in this case if who's a good surgical candidate or who may benefit from this therapy. Our mean was about 11% for the 30-day mortality risk, and unfortunately, none of that scoring, although quite detailed, includes heart failure patients or the sequela of heart failure. So it's not a great, predictive factor who may benefit from this therapy. And our conclusions for high-risk patients due to low EF and medical comorbidities, the preoperative placement of this Impella device may actually improve outcomes, and it really deserves further investigation. And it represents the largest experience so far in the literature regarding the perioperative hemodynamic support with this prior to high-risk cardiac surgery. There's increased interest in this nationwide, but many surgeons are not as familiar with this device, being the newer implementation, and then also how to coordinate it with implementation during the operation itself with the aortic prosthetic. So that's something that we need to work on as far as the national education in order to benefit patients. And it may be a way to optimize and kind of beat the odds, if you will, to allow cardiac surgeons to take on cases that previously would be deemed as prohibitive or extreme high surgical risk.
Question. For these patients, I don't know, to be honest. The post-operative ejection fraction generally tends to improve over a period of 30 days post-operatively, so it would be best to assess their ejection fraction improvement after that 30-day period, and I don't have that data for these patients at this time. I think they would do So for these specific patients, the other options that are available to us are which are commonly used. Unfortunately, I think that would have been insufficient for the patient population. And the other factors that we can use for the ECMO support is basically intubations for your bypass,
versus actually implantable left ventricular or right ventricular devices. Much more invasive and requires operating. So the use of any of those other modalities is extremely high risk of postoperative morbidity and mortality. ECMO ends up with ECMO for the period of 3 to 5 days, which is what 50% of patients survive. And so using those modalities, they will have a much lower survival rate. Many of these patients that we surgeons do not operate on because of that potential high risk of needing one of those modalities for postoperative high risk. That's the point that really have to be cared to, because that's not something that you want to take from industry. So more salvage therapy, like oxygen therapy, they use for it, more salvage.
Okay, thank you very much. And I'd like to remind everybody to go back downstairs for our keynote speaker.